pigmentary fundus with uveitis, how to proceed. So we'll be having the speakers one by one, and later on we'll be having time for discussion with the audience.
Thank you very much, Reema, for inviting me. The topic that Reema has given to me is pigmentary fundus with uveitis, how to approach. Well, whenever you see a patient who has a lot of pigment and uveitis, the first thing is to look at, has there been any past evidence? Are the episodes of uveitis? If yes, the pigmentation could simply be the result of the healing, and now there are new recurrences. However, the problem is if there is no past evidence, then what it could be? It could be infective uveitis, and syphilis very typically produces salt and pepper kind of lesions, which to my mind is the true kind of pigmentary lesions. There are retinal dystrophies, which sometimes do have cells which are mistaken with vitreous inflammation. Then there are malignancies including lymphomas and B-dump and rarely PPCRA. Now let's go over them one by one. Suppose you see this patient with few cells here and there and the lesion which is pigmented. Now this kind of the lesion is most likely due to the past episode, and if you ask patient to show you the previous picture, you will realize that it was a case of macular serpiginous-like, which had healed on to produce the pigment. So then it becomes a very simple and straightforward case of healed uveitis. The problem occurs when you see lesions like this with cells in the vitreous. For example, this is a 28-year-old male who's being treated as retinal vasculitis. I'm sorry about the quality, but left eye you will see there is something happening along the vessels. There are no AC cells, but there are vitreous cells. And when we do the fundus picture, we do see there are diffuse pigmentary changes, which are looking like bony spicules. But the problem is this. Somebody was confusing it with vasculitis, and patient was diagnosed as retinitis pigmentosa with uveitis. Now that is, to my mind, a criminal diagnosis, because that's not how it works. So when we did the ultra wide field left eye, it showed astrocytoma, diffuse pigmentary changes, with periarteriolar sparing, which is very characteristically, you can see that arterioles are spared. So this is actually CRB1 mutation, associated Leber's congenital amaurosis. So you need to diagnose it, not because you are going to treat Leber's amaurosis, but at least you are sparing your patient giving unnecessary corticosteroids and immunosuppressants, because you are diagnosing it as uveitis. So that is a pigmentary lesion. This is another example of a 43-year-old lady who presented with complaints of progressive decreased vision. She was actually diagnosed as serpiginous choroiditis. Best corrected was 618, there were no cells. It looks like serpiginous choroiditis. And if you see it casually, you may mistake it for serpiginous choroiditis. But look at the symmetry of the lesions. So this is the autofluorescence. The lesions are too symmetrical, they are too flat, and they do not have an edge. There is normally an edge in the inflammatory serpiginous choroiditis, which is totally missing here. So this is actually a case of helicoid peripapillary chorioretinal degeneration, which is also called Stevenson chorioretinal atrophy. So please, all these dystrophies like CRB1 mutation I showed earlier, or this one, or even retinitis pigmentosa for that matter, is going to have few cells in the vitreous. That does not make it uveitis. Just to distinguish it from the true serpiginous, this is the picture of the true serpiginous. You do not have uniform Hypo, like what you're seeing here, what you have is the edge which will be active, and even when you see here, there is a volume to it in inflammatory lesions, which you don't have in dystrophies. And this is how the centrifugal spread, exposure of choroidal vessels, and mostly asymmetry between the two eyes. That's how you will distinguish. This is a patient with Mudit, and I just added it to complete the picture, that this is also a case of a pigment with uveitis, and when you look at it, you could think of serpiginous like choroiditis, because you do have the yellow lesions, you do have pseudopodia like, and you do have something happening here. In fact, if I see it the first time, my first thing is, could it be TB? But as you see, he has done a beautiful OCT through the lesion, which shows a choroidal mass there, vitreous cells, but the patient was positive for VDRL and TPHA. So was treated with crystalline penicillin, and this is how patient responded. So syphilis, as I said in the beginning, can produce pigmentary lesions, which are like salt and pepper, but this could be just an example of how syphilis can mimic almost everything in the eye. This is now switching gears to B dump. When we look at the B dump, you don't exactly see pigment, but what you see is there are some pigmentary disturbances, but orange-ish color subretinal patches. So it's very important not to mistake it with lymphoma at this point of time, because two of lymphomas and B dumps have different etiology. So when we do the autofluorescence, B dump very beautifully shows the lesions which are hypo and hyper, thickening of the choroid. Macular edema actually is not typically a feature. This patient did have serous detachment can happen. And the clue comes from fluorescein. When you do fluorescein, there is early hyperfluorescence on angiography in patients with B dump, which does not happen either in retinitis or in choroiditis or even in lymphomas. So you can see the early hyperfluorescence. You know that in this patient you have to look for a malignancy, and the most common site of the malignancy would be reproductive tract or GI. So if you see a picture like this, bilateral diffuse melanocytic pigmentation, and your age group is such, and there is early hyperfluorescence, important to rule out malignancy, because this is classically B dump. Last is lymphoma. Now this patient, actually very old patient, and somebody thought it was a patient of retinitis pigmentosa in the right eye, and this was the left eye, which shows disc edema, which shows subretinal lesions, and which shows these yellow lesions. So this is what is lymphoma, and if you do OCT through this, lymphoma deposits are typically between the RPE and Bruch's membrane. So this was a diffuse large B-cell type of lymphoma. Important to do MRI, because many of them may have associated lesion in the brain. And this is how the lesion heals, which produces pigmentary lesions. So I come back to this from where I started. Pigmentary fundus with uveitis. Look at the past evidence. If there was infection, it is straightforward. The problem is if there is none, rule out syphilis, rule out retinal dystrophies, and this is the thing which bothers me, because many of us do not really rule out the dystrophies, and we make the diagnosis of retinal dystrophy with uveitis, which is where we mistake. Malignancies, PVRL, B dump. PPCRA I did not have time, I did not show, but it's a very classical picture. But that's more on autofluorescence rather than showing the gross pigment in the fundus. Thank you very much, Reema, once again for the opportunity.
Thank you very much, ma'am, for highlighting such beautiful cases. We now welcome Dr. Prof.Reema Bansal, who will be presenting on fluorescein angiography in posterior uveitis. When is it and when not?
Thank you, Dr. Reema. I'll take you quickly through a number of images of fluorescein angiography without going too much into the theory of it. So why do we do fluorescein angiography in uveitis? As you will well understand, that the idea is to look at retinal vascular inflammation primarily. It could be a direct involvement of the retinal vessels, or it could be a surrogate measure of the inflammation in the retina as such. Per se, retinal inflammation, which we call as retinitis, does not need fluorescein angiogram, because most of these, as you will know, are recognized by pattern recognition. For example, toxoplasmosis, ARN, etc. The problem with fluorescein angiogram is that it doesn't give you much information about the choroidal inflammation. So let's quickly run through. Yep. So this is straightforward retinal vasculitis. What do we find? We find that there is perivascular leakage, but the point to note here is, if you look at the color fundus photo, more of the perivascular infiltrates are found in this infratemporal quadrant, but that is not leaking so much on the angiogram. The real activity is around the posterior pole, and that is what you pick up on the angiogram. So it tells you where the activity is. Then the macular ischemia or CME identified by the petaloid pattern. The areas of capillary non-perfusion, you see large ones over here superiorly. And sometimes you can differentiate, as you can see here, between collaterals and the NVE. Now this is a 26-year-old male with a drop in vision since 2 months, and you can see the fundus photos of both eyes. I think all of you can appreciate the retinal vasculitis here, but how did fluorescein angiogram help us here? You can see that there is large area of vascular, the capillary non-perfusion. You can see here many collaterals have developed. But you also see that this yellow lesion at the macula is becoming very intense hypofluorescence. Please note the word intense and hypofluorescent. You don't see this kind of intensity in a choroidal lesion. It won't cause such intense hypofluorescence. And as you look at the later phases, you see a perilesional hyperfluorescence. This perilesional hyperfluorescence is a sign of retinitis. It's not a sign of choroiditis. So when we run a OCT through this lesion, you can see that the lesion is entirely retinal. And this is the lesion that we call as subvascular lesion, and which we find in TB endemic countries are very classic representations of TB retinal vasculitis. The patient also had an open TB contact, and he was MON2 and QTB positive. So this is what we have published earlier. This is the active subvascular lesion. This is the healed subvascular lesion. This is a new entity that we have reported, which is the focal vascular tortuosity, which is away from any capillary non-perfusion and is within the area of vasculitis. Then the occlusive vasculitis. So if you see all these features in an eye with retinal vasculitis, you should be strongly suspecting tuberculosis as the etiology. This is another retinal vasculitis with a retinitis lesion, but this is the only case where a retinitis is non-infectious. Can anyone guess what this is from the extensive ferning around the vessels on the angiogram? That is Behçet's disease, right? And the answer comes on the anterior segment in the mobile hypopyon that you see in this patient. Now, interestingly, the other eye of the patient had a classic retinal periphlebitis, which you can see in any other etiology. So remember that Behçet's is not just about the ferning, it can also produce periphlebitis like you see in the right eye of this patient. Now this is one place where there is not much of hardly any perivascular exudation, but there is a huge retinal hypoperfusion, and this is classic of many forms of occlusive vasculopathy, one of which is Takayasu's. You can also see this in SLE or in Suzak syndrome. This is from the hypertensive phase of Takayasu's, and you can see a branch retinal artery occlusion over here, and ischemic optic neuropathy, and multiple microaneurysms which are picked up on the FFA. Now let's move back to something else. This was a patient of retinal, of intermediate uveitis who was being treated on topical steroids because there's no inflammation seen in the posterior segment. However, when we did an OCT, we found a CME in the left eye of this patient, and when you do the fluorescein angiogram, you see the extensive leakage that you can pick up on the fluorescein angiogram. This shows the extent of retinal inflammation in this patient. So, this patient had a negative MON2 and TPHA and a few enlarged lymph nodes on the CECT. Right. So this is seen here. And this patient, on the other hand, you can see the floaters around in the vitreous. Okay. You will think that there is an intermediate uveitis, there is an inflammation that you need to treat in the posterior segment. But when you do the fluorescein angiogram in this patient, you see that the vessels are hardly leaking. So these two cases give you an example how a fluorescein angiogram helps you in distinguishing true inflammation versus pseudo-inflammation irrespective of the vitreous haze in that patient. Okay. This is another case. This was a 14-year-old female diagnosed as intermediate uveitis elsewhere. But when we carefully looked at this patient, I'm sorry, there's some kind of, okay. So this patient was treated with corticosteroids and methotrexate, and we thought we were doing.
Call me for this talk, and I don't do the ultrasound, but I interpret and use it for uveitis. So I'll be talking my experience of no view of the fundus, where you do the ultrasound, UVM, and others. So I thought that there's conditions which can obscure the posterior segment evaluation are endogenous endophthalmitis in top on the list, and where you need to distinguish an pan-uveitis, non-infectious pan-uveitis, viral retinitis, complicated cataract, vitritis, vitreous hemorrhage, occlusio pupilli. So I would first like to work up the patient. I would go into the history, like medical history, surgical history, travel history, social history, family history, and morphologic type of uveitis, anatomic type of anterior, intermediate, posterior, pan-uveitis. Look for the systemic features, recurrence, is there any or not, previous therapy, risk factors, and then I go for evaluation of the fundus. Pointers of the uveitis versus endophthalmitis. This is a post-operative immunocompromised state, will go more towards the endophthalmitis, history of trauma, history of fever, recurrent episode, no history of IV infusion, like contaminated solutions can produce endophthalmitis. So there are the ancillary investigations, two are in our hand. One is the ultrasound B-scan evaluation, and next is the ultrasound biomicroscopy, UBM. Ultrasound B-scan, 77.5 to 10 megahertz, real-time high-frequency probe with the contact method. And what we get is that we can determine the rhegmatogenous versus exudative retinal detachment, choroidal thickening, T signs like tenon space and widening, posterior scleritis, mass lesion, tumor abscess, or choroidal mass lesion due to tuberculosis like tuberculoma. It's a reliable, safe, cheap, and rapid investigation to identify. The slide here in that middle is showing vitreous tractions and retinal detachment. We had a very interesting case, degenerated intravitreal cystic cirrhosis, masqueraded as endogenous endophthalmitis. We thought that is the endogenous endophthalmitis. When you did the ultrasound, you get an hyperechoic mass lesion in the vitreous cavity, and this was the patient couldn't understand that what it is, and then the patient had undergone a vitrectomy, and the vitrectomy specimen, when it came to me, I looked into the slide and I found there's a hooklets over there in the vitreous cavity, and which was polarized with the light, and you can see in the polarized light the hooklets of the vitreous cavity. It's a very, very, very unusual and interesting case, and in fact, some of the times intravitreal cystic cirrhosis can be hidden and can be diagnosed with ultrasound. And this is the case of vitreous hemorrhage, and here is the most crucial point: is the retina underneath is detached or not? So here we can see that there is no detachment of the retina. The intergel echoes are seen, moderate internal reflectivity. And this is a case of which we say recently, 39-year-old man, sudden dimness of vision, left eye for 5 months. He is HIV positive on ART, diagnosed 3 months before. History of herpetic skin infection. And we found that the yellow lesion in the fundus, and there's a very hazy view of the fundus. We did a vitrectomy, and vitrectomy showed uveitis genome positive and fungus negative. Gram-negative bacilli was seen in the culture and sensitive to the ciprofloxacin, moxifloxacin, gatifloxacin. Right eye has the flare and cells. Look at the ultrasound pictures. Ultrasound showed vitreous low to moderate, few to moderate low reflective echoes, partly detached posterior hyaloid with good upper movements and not persisting in the low gain, causing focal traction in the nasal and superior quadrant. Plenty of mobile low reflective dot echoes in the subhyaloid space, suggestive of subhyaloid hemorrhage. And the choroid is diffusely thickened. And this indicates that the patient is having an endogenous endophthalmitis. This is another case, 35-year-old female, complaint of right eye pain, redness, dimness of vision, and curtain-like thing is falling in front of the eye. Vision was 6/12, anterior segment, mid-dilated pupil, congestion, posterior synechial cyst, posterior segment choroidal mass lesion involving extending the root of the iris. And QTB is positive, and PCR showed eubacterial genome targeting 16 sRNA region positive. And this is the lesion which you could see, and I made a drawing of that one, and then you can see the yellow color lesion. And there is the lesions in the anterior segment and iris, and fundus showed a lesion with a little hazy view of the fundus. You can see a large, huge granuloma. And this was a tubercular granuloma. And we did an UVM. UVM showed large ciliary body mass lesion. And this large is a 6 o'clock positions, approximately measuring 3.02 to 6.8 millimeter, measuring in the radial clock positions involving the angle and the anterior quadrant. 360 degrees supraciliary effusion was seen, and ciliary processes imaged blunted in inferior quadrant and shorter in the rest of the clock hours. And if you look at the ultrasonography, vitreous showed few low reflective dot echoes, and a diffuse mass lesion noted inferiorly with medium to low internal reflectivity, and with the following dimension, basal 7.56 millimeter, height 4.87 millimeter. Vertical is that one associated retinal detachment noted in the inferior nasal quadrant. History is this is a 60-year-old doctor. He happened to be my roommate. Actually, he had a COVID infection. His vision in the hand movement and posterior segment yellow glow in the fundus, and ultrasound. This is the picture of the eye is a quite disturbing, and this patient had vitreous showed moderate number of low reflective dot echoes, more inferiorly and temporally, retina attached throughout, choroid and optic nerve head attached throughout. And we did the vitreous biopsy, and it showed KOH calcostain fungal filaments. And the culture showed fungus on chocolate agar and blood agar. Last case is 24-year-old male, complaint of dimness of vision and redness in a week in the right eye. HLA-B27 was positive, and we are thinking that is the HLA-B27 pan-uveitis. When I looked into the eye, it told me that the fundus glow should not be go with the pan-uveitis. I told them there is an endogenous endophthalmitis, and my VR colleague was not believing me, and then I persisted on it, and this is the picture on that, and ultrasound showed low to moderate reflectivity, and retina attached throughout, choroid and optic nerve shadow normal, no evidence T-side. And the patient for PCR for eubacterial genome positive, ultimately after vitrectomy, patient got back some vision. He is very comfortable now. So final diagnosis is endogenous endophthalmitis. Ultrasound biography, I'll go very quickly. Configuration of the pars plana, peripheral retina and vitreous, snowbank in the intermediate uveitis, vitreoretinal adhesion, vitreoretinal traction, and UVM. And this is a pars plana, the limited view of the fundus. And you can see the pars plana exudates, which after treatment disappearing. And this is the iris nodules and ciliary body nodule in a tubercular granuloma. And here is the ciliary body detachment with normal ciliary processes, and shallow anterior chamber with ciliary body atrophy. The decision regarding cataract surgery, sometimes the view is not there. It's very important to get that ciliary body processes and general support, atrophy ciliary body, high risk of hypertony, and you need to decide whether you need to combine with the vitrectomy or not. We did a study of, reported a case of pars planatis caused by the caterpillar hair, and which is shown over here in the ultrasound, UVM showing a nodular lesions. We also have found out a case of gnathostoma spinogerum, which was disappearing, and we could find out the gnathostoma in the root of the iris ciliary body area, which was published in American Journal of Ophthalmology 2005, before they have stopped publishing the free articles, letter to the editor. So in conclusion, ultrasound and UVM are valuable tools in no view of the fundus or limited view of fundus, even in clear media on mid-to-mid ultrasound. This is the last slide. Ultrasonography done in clear media, posterior scleritis, VKH, sympathizing eye, sympathetic ophthalmia. I think this is an invaluable tool. Ultrasound biomicroscopy done in the clear media, caterpillar hair, ocular trauma, hypotony to rule out ciliary body detachment and ciliary body atrophy. I'd like to thank everybody, and we continue to follow the legacy of the Professor Dr. S.S. Badrinath, Padma Bhushan Dr. S.S. Badrinath, who is my mentor and chief, and we follow the principles and the life of this great man.
Thank you very much, sir, for the wonderful cases. With this, we now move on to another topic which bothers us all the time in uveitis practice, which is uveitic macular edema. What to do when it's persistent? So I call upon Dr. Padma Malini Mahindra Das to be speaking on this topic. Please keep your questions ready, so we'll have them up during the panel discussion.
Good afternoon to all of you. And outside, I'd like to thank Dr. Reema for inviting me here today to speak on uveitic macular edema, what to do when persistent. Macular edema is a macular thickening due to abnormal leakage, accumulation of fluid in the macular area, owing to the breakdown of outer and inner retinal barrier, leading to increased permeability of the retinal pigment epithelium and retinal vasculature. It causes severe impairment up to 30% in uveitic patients. Macular edema is considered persistent if the retinal thickness persists even after 6 months of treatment. The macular edema varies between different types of uveitis, the commonly seen in pan-uveitis, followed by intermediate uveitis. Coming to the risk factors, it could be secondary to systemic or local risk factors. The systemic have associated diabetes, hypertension, or smoking, obesity, and increasing age. Coming to the local risk factors, the breakage of the retinal barrier alterations, recent history of intraocular surgery, or associated with inflammatory choroidal neovascular membrane or presence of epiretinal membrane causing the traction. Coming to the pathophysiology, there is a loss of equilibrium between the water influx and efflux. Increased influx of fluid, breach in the blood-retinal barrier, which causes increased oncotic pressure, causes vasogenic edema, activation of Muller cells, decrease in PDGF, increase in VGGF, and increase in inflammatory parameters like TNF-alpha, interleukin, and prostaglandins. Decreased efflux of fluid occurs Muller cell dysfunction, and also the microglial cell activation and RPE dysfunction results in cytotoxic edema. When there is a presence of vasogenic as well as cytotoxic edema, results in uveitic macular edema. So it's important we need to understand what is the pathogenesis occurring in each case. Accordingly, we have to plan our treatment. Coming to types of macular edema, uveitic macular edema, it could be a cystoid macular edema, which commonly we see, or diffuse macular edema, cystoid macular edema associated with subretinal fluid. And now we'll move on to case examples. This instruction course is based on the cases, so now we'll see cases. First, case 1 is a case of a persistent macular edema. It's a 47-year male Diagnosed have a case of bilateral retinal vasculitis with cystoid macular edema on treatment since 2 years before the patient presented to us. He gave history of treatment with oral azathioprine, then switched over to oral mycophenolate meftil. Patient received multiple local posterior subtenon injections and intravitreal anti-VEGF agents. At presentation to us, the patient was on treatment with mycophenolate meftil, methotrexate. When we investigated what was the reason, the patient had lupus antibody was positive, whereas other investigations were negative. This is a clinical picture. The visual acuity at presentation was 618 pads in the right eye, 6/9 in the left eye. Anterior segment was quiet, lens was clear. We could see the vitreous haze, posterior vitreous detachment, and also we can see a focal areas of vasculitis with chorioretinal laser marks in both eyes. When we did the OCT, we did notice cystoid macular edema with subretinal fluid in the right eye. In the left eye, we could see ERM with intraretinal cystic spaces with subretinal fluid. Both eye, the patient received anti-VEGF with continuation of systemic therapy. FFA showed perivascular leak, disc leak, and staining of the vessels with capillary non-perfusion areas. This is the late phase showing the disc leak and staining of the vessels and leakage from the retinal vessels. In spite of anti-VEGF therapy, there was recurrence of macular edema. Always there was some amount of cystic spaces were persistent in both eyes. So when we referred the patient to the rheumatologist, systemic evaluation was done based on the systemic parameters. They decided to go ahead with a rituximab injection for this patient. Following rituximab, we could see reduction in the macular edema. However, there was persistence of cystic spaces. We discussed and we went ahead with intravitreal Osidex, and MMF was changed into cyclosporine. So following which we could see the resolution of the macular edema. However, the patient has become steroid responder. Then injection adalimumab was continued, started, and however, there was inadequate response to adalimumab also. So we did the inflammatory cytokines from the ears, and we did notice interleukin-6 was elevated. Discussed with the rheumatologist, we started on injection tocilizumab. So following the tocilizumab, we could see the resolution of the macular edema and resolving edema in the right eye. This is at presentation. Patient had MMF with methotrexate. Anti-VEGF did not respond. Rituximab did not respond to satisfactory results. Osidex was okay, but however, the intraocular pressure was went up. Adalimumab, we did not get satisfactory response. Finally, the patient responded to tocilizumab. Next case is a persistent macular edema, 56-year female, presented with transient blurring of vision in the right eye for 6 months. History of fever 2 weeks back, where we could see the central retinal vein occlusion in the right eye with macular edema in the right eye. Left eye OCT was normal. FFA shows block fluorescence corresponding to the areas of retinal hemorrhages in the right eye. In the late phase, we could see the disc leak, staining of the vessels with leakage. And this is a diffuse perivascular leak with a disc leak in the late phase. When we investigated, dengue, IgG, IgM was positive. Serum ferritin was elevated. HLA-B51 was also positive. IGRA was indeterminate. We started the patient on oral steroids. Immunosuppressions with methotrexate was started. Anti-VEGF was given injection. Avastin was given to the right eye. Subsequently, we can see the resolving macular edema in the right eye. 2 months post anti-VEGF, again there was a flare-up of macular edema, advised Osidex. Patient developed steroid responder. It was okay. Once the effect is over, the macular edema started appearing again. Advised intravitreal anti-VEGF. Post 1 month anti-VEGF, we could see the resolving macular edema. Again, the macular edema bounced back. 2 months anti-VEGF, repeat intravitreal anti-VEGF agents. Following which we could see the resolving. Started on systemic cyclosporine, intravitreal anti-VEGF, methotrexate, cyclosporine, and intravitreal thing. With that, the patient this is the course of action. Recurrence, steroid response, anti-VEGF, post anti-VGF, and now the patient last 1 month they're doing well with cyclosporine. The next case is a persistent macular edema, 60-year male, defective vision since 3 months, treated with ATT and oral steroids for retinal vasculitis. Here again the patient is a steroid responder on oral methotrexate as well. This is a fundus photograph. Right eye had posterior subcapsular, left eye was a pseudophakia. OCT shows lamellar macular hole with intraretinal cystic spaces in the left eye. So we have used topical interferon for a uveitic macular edema. We have published our results in Indian Journal of Ophthalmology. We have tried topical interferon therapy for this patient, following which we could see the resolving macular edema. Coming to the treatment algorithm for macular edema, first we need to see whether it's infectious or non-infectious. If it's infectious, in addition to antimicrobial and anti-inflammatory therapy, we can control the edema. Whereas in non-infectious uveitis, it is chronic. First line will be the corticosteroid therapy. If the patient is not responding, second line we can use immunosuppressive therapy. Either it could be methotrexate, azathioprine, MMF or cyclosporine. If they're not responding, then anti-TNF agents. We also started using interferon alpha topical therapy. In addition to that, we can combine with intravitreal dexamethasone implant or anti-VEGF to control the macular edema. Coming to the bilateral thing or unilateral. Unilateral, again, if it's mild, treat them with periocular steroids or intravitreal steroids. It's moderate, we go for the intravitreal steroids or systemic therapy. In bilateral, again, the similar sequence, steroids or intravitreal implant, systemic immunosuppressive therapy, anti-TNF, and refractory cases, we find topical interferon is found to be effective. Earlier we were using 4 times a day. Now we started increasing the frequency up to 6 times a day, and they respond well to treatment. Coming to the treatment, we treat them with topical, local or systemic therapy depending upon the type of the uveitis and the severity of the macular edema. Topical NSAIDs work well for mild post-op uveitis. The topical steroids, difluroprednate, has a penetration into the posterior segment, effective in controlling the macular edema, and topical interferon also is useful. Coming to the local therapy, it could be the periocular or intraocular steroids, anti-VEGF agents, and anti-TNF intravitreal agents also can be used to control the macular edema. Coming to systemic therapy, we use systemic steroids, immunosuppressives, biologics, and refractory cases, tocilizumab, IL-6 inhibitor is found to be effective in treating chronic refractory macular edema. I'd like to acknowledge my colleagues for the contribution. Thank you for your attention.
Thank you very much, Dr. Padma. So we now move on to our last topic of this session. We have Dr. Mudit Tyagi, who will be talking on ignoring patients' subtle complaints, what can go wrong.
All right. Good afternoon, and first let me thank Dr. Reema Bansal for having me as a part of this great IC, and to all my co-speakers and chairperson and AIOC scientific committee. So I'll be talking about what happens when we ignore the subtle complaints of our patients and what can go wrong. Now, the thing is that as clinicians, often we tend to sometimes kind of overlook what our patients are telling us, try to in a hurried clinic ignore some of their complaints, but please, we should remember the fact that the most important person in that room is our patient, and sometimes they're extremely perceptive of their complaints, and probably what we can learn from a good history is something to which there can be no alternative. So let me show you a few examples where things can go devastatingly wrong if we end up ignoring what our patients are telling us. So this was a 40-year-old male patient from Hyderabad who came to us with a complaint of a central scotoma in the left eye since just one day. He had shown somewhere elsewhere and he was told that there's a small hemorrhage in the eye, there's nothing to be worried about, it's probably because of hypertension, go and get your BP checked. But there's no history of trauma, no history of any strenuous exertion, no systemic history, though he does give you a history of a gastrointestinal stromal tumor removal around 10 years back. No other systemic or significant clinical history otherwise. His vision was 20/25 in the right eye, 20/50 in the left eye. This is the right eye, which is absolutely normal. If you look at it, there's a small subhyaloid hemorrhage over here, or sub-ILM hemorrhage over here, through which an OCT was done. And he had been initially told that there's nothing to be worried about, this hemorrhage will go away, let's observe it for around 2 weeks. But this patient was extremely insistent about the fact that this is something which has just happened 2 days back, and he can perceive a very significant scotoma in his work. So when we started looking at him, this is what we found. Apart from the sub-ILM hemorrhage, this is what we found. There was a single white-centered hemorrhage, just one single hemorrhage over here. And when we got this patient investigated as to why does he have this in the first place, along with one small streak hemorrhage here, and this is the OCT showing that small hemorrhage, the subileum hemorrhage. Differentials usually for white-centered hemorrhages predominantly range between blood dyscrasias and occasionally endocarditis. So while there was no other thing, he did have a hepatosplenomegaly, which you can probably also attribute to the past history of the GIT that he had. But to our surprise, his WBC counts was significantly elevated. It was 1,39,000. And when we did a peripheral blood smear, what we found was myeloblast, promyelocyte, metamyelocyte. This was actually a case which was Philadelphia chromosome positive CML. So a single white-centered hemorrhage, which could have been ignored, helped us in arriving at a diagnosis of this patient having a CML. And that's where it's important for us to look at what the patient is having and to listen to every single thing that our patient tells us. And therefore, it becomes important for us to listen and attribute their clinical features and not just dismiss them altogether. This was another patient. This is a patient who had a past history of toxoplasmosis. Again, came a week earlier with a complaint of slight decrease in vision, was told that the other eye is normal and was sent back. But this patient came back again saying that she is still perceiving the same problem. And now when we look at the right eye, we see this over here. There is an active toxoplasma retinochoroiditis which was initially missed. So the point here is that when our patients tell us that they can feel a slight difference, the vision at this point of time was still 20/25 in the right eye, mind you. But that is because the lesion was away from the fovea over here. There is a small amount of fluid, but this patient perceived a small scotoma, small decrease in vision, and she came to the clinics. And therefore, it becomes important for us to look at the other eye and examine our patients in detail. Another subtle point which can often go overlooked is when a patient comes back with a hypopyon. So a hypopyon in a known case of leukemia, and if we again miss up, again that can invite trouble, because a hypopyon in a known case of leukemia can alert us to the possibility of either a relapse or a blast crisis. So patient of leukemia, if they come to you with a hypopyon, that can be often a first indicator of the patient either going into a relapse or an impending blast crisis, or occasionally also a CNS involvement, because these cells through the leptomeningeal arteries come over here and through the ethmoid arteries come over here into the anterior chamber. So when you see a atypical hypopyon in a patient of leukemia, please be extremely wary. Check them for an impending blast crisis. Get a MRI done because and send them to the treating oncologist, because this can also herald the neurological spread. Again, I'll just like to show you some cases where a possible history would have saved us. So this is just an example of the case and a background to what I'm about to show you next. So these are cases which we had published where our patients came to us with a history of an AC inflammation and choroidal detachments and hypopyon. And what we found was that this was a patient who was using topiramate. So when this patient was seen, they were initially thought of as an angle closure. Somebody attempted doing a surgical PI over here in this patient, which led to this intumescent cataract. And these patients developed a chronic persisting inflammation later on. What we failed to notice was that this was a patient who was taking topiramate. All that this patient needed was a discontinuation of topiramate and starting the patient on topical steroids and cycloplegics like atropine, and that would have taken care of the entire problem. If you end up missing that, this is what can happen. Now I know this picture appears ghastly, but what had happened over here was this again was a patient who had presented somewhere with a complaint of sudden angle closure, and therefore they decided to remove the intumescent cataract. In the process, the cataract was removed, but all of this subsequent inflammation occurred. And this was a patient who was taking chlorthalidone. So whenever you see patients with an atypical presentation, it makes sense for us to pause, listen to their complaints and go back and take a history. More importantly, what are the drugs that the patient is using? So drugs like chlorthalidone, topiramate are all known to cause AC inflammation, angle narrowing, and intense choroidal detachments also. If we can stop those drugs in conjunction and discussion with their treating physician and start them on topical steroids and atropine, that will take care of the entire thing instead of leading to complications like this, where subsequently we had to do a membranectomy, remove those ciliary body membranes and put oil inside the eye. But all of this could have been avoided if we had again taken a history, paused and listened to our patient. Last example, this was a patient who had a past history of ARN. Since 2016, was doing well for 5 years continuously. He lives in Dubai, had a complaint of a slight decrease in vision, went to their treating physician in Dubai, was told there's nothing to be worried about, your eyes are fine. But what had happened is that the patient had a history of a COVID infection in 2020, and we had already seen few cases where there was a reactivation of ARN post-COVID. So while this patient did have a vision of 20/20, he was able to perceive a slight decrease in his vision, and when he came to us, what we noticed was that there was a peripheral reactivation of ARN in this eye. He was started on valacyclovir again and is now doing well. So in a nutshell, what can happen when we ignore our patient's subtle complaints? And the answer is everything. And therefore, we need to be careful of what our patients tell us. And once they tell us something, to subject them to a complete meticulous ophthalmic examination as well as a good history for these patients, because those clues can itself help in changing our entire treatment paradigm. Thank you so much.
Thank you very much, Dr. Mudit. And thank you very much to all my, Mudit, you can, it's, so I'll take a. So we are open to panel discussion, and this is with the interaction with the audience. So we are open to questions. For any of our speakers, you are welcome to ask.
Intentional scarring or controlled scarring, so that we can save at least a posterior bone. So the guy is very young, just 30, and this is third recurrence for him.
So,
If we mix the two cases, then.
so the problem with the recurrence of EKH is because to begin with, the treatment had not been intensive.
It's very easy to blame. It's very easy to blame the patient and very easy to blame the retinal doctor. That boy wasn't for that boy wasn't for approximately 4 years. Was on different drugs, metho, cyclophosphamide,
Yes,
and that.
yes.
So-
The problem with that boy, if I recall it correctly, the end point of immunosuppression is 2 years after the disease has been quiet. Now, disease might take 1 year to become absolutely quiet, which means you have to add 2 years of immunosuppression post that. The tragedy with that boy was with steroids, he developed vascular necrosis of the hip, so he was off the steroids, and then he was on immunosuppression, which he did not take in the appropriate dose, and he also developed bone marrow. So when I saw him, we gave him azathioprine, he responded, but then, he was fine for 1.5, 2 years, and he stopped it on his own. So, no, I'm not saying any one of us is doing bad. The thing is, when you are at a point where you want to reduce or stop immunosuppression, you should have an ICG to look at the subclinical disease. Because any patient who has been fine for 2 years is not motivated to take it for the longer. Like we all do that. I never complete my antibiotic course. I get well in 2 days and stop it. So that is what happens. So, without ICG, without monitoring subclinical, if we stop it, the disease comes back, and that's what happened in him. In him, Ozurdex is not the treatment for VKH. It is a systemic disease. There is no role of local therapy. So he was given systemic therapy, which is, I think, adalimumab he was started on, and azathioprine. But these drugs take time to act. And since we could not give oral steroids, Ozurdex was just an add-on. Ozurdex is not the treatment for VKH.
The whole idea for, let's say, discussing my point is that I want to control starting that it may help or what is your take?
In uveitis, we don't try to kill it. We try to preserve as much melanocytes as we can because we have alternative therapies in the form of biologics, aggressive immunosuppression to begin with. So it's not like retina that we will kill the entire retina and save the posterior pole by laser, because we have the therapies where we can preserve the good vision. So that's not the treatment.
I just like to quote on this. What we see in usually the tip of the iceberg, and we see that clinically it has healed, but there's a lot of inflammation, maybe remain quiescent over there for a long time, as it's told by Dr. Vishali that maybe 2 years, and nobody knows it. I have got an experience of an eyeball, a patient who had somewhere had phthisis bulbi one eye. Other eye was doing well, absolutely, 2 years. So the patient for cosmesis wanted to remove the eyeball. The eyeball was removed. I thought that it will be another phthisis bulbi where you see the calcifications and all. I could see the inflammatory cells. Choroid is full of inflammatory cells, focus of inflammatory cells. And we and Dr. Dipankar Das did the immunohistochemistry, and we surprisingly found that it's not T cells, it's the B cells were seen predominantly. We tried to publish it, and it got published, but not in the PubMed Index journal.
Please go ahead.
It's an interesting thought about using tarring to probably think of saving the posterior pole, but unfortunately it doesn't work that way. The problem is that laser in itself is not do all the difference. Over an eye is not actually inflammation. If we end up doing intense laser, if you remember the earlier time when we did not have the pattern laser and we were doing the whole single point laser, there have been times when we have done a heavy laser for a patient with diabetes, they used to come back occasionally with an aggravated retinal also. And the reason is the laser in itself can occasionally cause an inflammation. So in an eye which has already got an inflammatory disorder and active inflammation is happening, doing a laser with the idea of scarring probably will not work. So I just want to discuss that one.
Literature, it is described that when the leakage is specific to the new vessels or a new vasculation, then they have done it and they have recorded it, and they have not.
See, there are two different. We are not dealing. We are dealing with the antibodies which are forming against the melanocytes. And if we look at the mechanism of laser, laser is not going to kill the melanocytes. And the amount of the laser you will have to do to kill all the melanocytes in the choroid will be unacceptable. So laser is per se not a treatment for the primary disease. For the complications of the disease where VEGF is elevated, and it can be done. Even for that, actually, you don't need mostly. And then she detached.
I think combining Ozurdex.
Yeah.
And now he just has a very minimal persistency and macular edema. The moment
I think Padma advises interferon topical. Yeah.
And I
She
think,
published it.
We'll
Topical
not
interferon.
really recommend Ozurdex in these eyes. You know, and second thing is, if you really have to go for something else, you can give a trial of anti-VEGF. Sometimes it works before you even go for, if you are hesitant with. That's a good idea because, you know, since the patient is not showing a remission, the patient is still having inflammation, you can continue the antivirals. But with this, if you're having the, you know, episodes of macular edema and all these, so better to try with anti-VEGF. It works in some eyes, and then you can go with the second line.
Something has changed about AN post-COVID. There are very severe, very fulminant lesions coming to the posterior pole. We used with hemorrhages, we used not to see them so fulminant earlier, and the viral load is really high. So the second point which I learned from my patients is don't go on a low dose of, because sometimes your fellows just start. The dose has to be maximum antiviral because there is a range. So go on the higher side of the range right in the beginning, and if required, introduce local therapy at the earliest, because the earlier protocols are not really working now the way they used to. Something is different.
I think
There is something different.
Yeah, we are seeing a crops of cases of ARN. I don't know why. And they are so fulminant and they are not responding to the IV acyclovir. We need to give intravitreal ganciclovir or foscarnet. Ganciclovir I will choose first because they reach a very high concentration of antiviral antibody.
And somehow they are developing detachment in the acute phase. Earlier they used to develop when they were healed. Now within 5, 7, 10 days they develop detachment and you have to go in a necrotic retina. So this is a new problem we don't know about.
So you have to, Parthu, you have to.
Yeah. So those who have dealt with this CME following year, you know, I think maybe a very rare complication. But even if you try all this won't go. So we have published a case. I never talk about it in any meeting. The reason is that I don't know how the audience will react and what message they will take home. That they may start injecting that. I published it because just for documenting that even after, and this CME starts typically after 6 months or 1 year after the resolution has happened sometimes. So those are the cases in giving the highest antiviral dose. We have given one patient Ozurdex after discussing all pros and cons that it can activate, because anyway the patient vision was 660, he was not getting, so finally he agreed. So the patient responded and we have given twice, it did not, after that it resolved. So I have told this to Alexandria University Dr. Rov. She actually went ahead and she had a similar case and she also tried that and it, but I think we must caution, means we have to be very careful that the audience should not take a wrong message.
So these are
out of it.
individual cases, you know,
Exactly.
Yeah.
they don't
And
convey a
long
general
after,
message.
6 months after the ARN has resolved completely,
So
and
let's
after
hear from
proper
Soumya.
discussion.
Just quickly, I think the macular edema is a manifestation of the inflammation and not of the infection. So if I have not dealt with a case till now, but if it was the case, I would do a fluorescein angiogram, look at the degree of the retinal inflammation on the fluorescein angiogram.
We have another case.
And if it is very significant, I would probably, and I've not done this by the way, I would probably give the patient a significant dose of oral steroids, okay, and under antiviral cover, but that is how it should be targeted. Local injections, while these have worked, I will be hesitant in giving local injections to these patients,
The patient
but treat with oral steroids.
Yeah, the
So
patient
let's
I'm
hear, okay, please.
No, the patient I'm telling was tried oral steroid. It didn't
Didn't.
go. Second is the similar case happened, one healed case of syphilitic chorioretinitis. As you pointed out, these are due to inflammation, not due to infection.
You know,
because
sometimes there may be a tractional component. We have to be very careful about the epiretinal membranes.
Only
whatever
problem
you-
with viral is it comes back. You know, it's hiding somewhere. It's not truly inflammatory. So in viral, it's very difficult to say that now infection is over, which we feel very comfortable with TBs and maybe syphilis also. With virus, you don't know when it will come back. That's the.
So let's hear from the expert on macular edema. Padma, I also want you to give a tip on topical interferon therapy, because many of us are not aware of it. So, they can go through your article, how to reconstitute the drops, but a quick tip for the audience.
Topical interferon therapy, especially we have reported a case of ARN with the macular edema, responded well to topical interferon. What we do is we are used to get the topical interferon. Intalfa is the one we were using it earlier. There it comes as a 1 ml solution of it. That we add 2 ml of water for injection, and we put it and keep it at -4 degrees. We'll ask the patient to store it and use it. So they use it for about a month. But now we are getting the Reliance One Reliferon that comes as 0.5 ml. In that we add 2.5 ml of water. So it comes a 3 ml solution, and they can use it 4 times a day. One patient assumed that I want the macular edema to resolve fast. He himself has put more number of dose, and we found that the response was good. So after that we started advising even 6 times a day. So it works well. Coming to ARN with persistent macular edema, I had one lady, and she never used, eye is quiet, the macular edema is so recurrent. And I put her on low dose of steroids for a longer duration of time, maybe about 3 months. It is in the initial beginning of the years. And then finally it responded well, antiviral with low dose of steroids. The second case, what we did was topical difluroprednate. It worked well for the second case. The third case, the recurrent one, responded to topical interferon therapy. These are the ones when the patient have persistent or recurrent macular edema following healing of ARN. We have used these 3 different modalities in our practice. Topical interferon works well. Having said that, we also face the interferon also, we had increasing inflammations on one patient. In fact, I gave it for macular edema. He developed hypersensitive reaction around the eye, and he came back with exacerbation of macular edema. That is anecdotal one case, but majority of them, they respond well to therapy.
So thank you, Padma. And yeah, please.
So I'm a rheumatologist. So question to Padma ma'am. The first case that you showed, I'm sure you managed with a rheumatologist. So what guided, you gave one agent after the another. So when we choose the agents for say rheumatoid arthritis or say lupus, so adalimumab is a common drug for uveitis. Rituximab we don't commonly use in uveitis. Again, in lupus, adalimumab is not a very common drug to be used. So what guided you to... I mean, till that time it was explainable because in lupus, rituximab is a common drug.
I think I'll interrupt. Sorry to interrupt. She's in a practice which is a very tertiary care hospital. We have access to multiple, rheumatologist consultation, and we can really, add a lot of drugs. But for you, for people, those who are in general practice, we understand it's not possible, and you shouldn't be trying these modalities. So if you think you are not able to manage macular edema beyond a certain limit, it's better to refer the patient to the tertiary center rather than, experimenting with these drugs, rather than experimenting with steroids, which makes the patient steroid responder and, does so much of harm. So that's the idea. We are all here together. So if you understand from the talks by the speakers that at a certain point, beyond a certain point, you cannot manage, please, you can take our help. You can write to us, or you can refer the patient to us.
Yeah. Okay. So will doing a tear fluid cytokine analysis help us to individualize the treatment right at the beginning instead of going through all this? Yeah, yeah. Yeah. And even in JIA associated uveitis, I think Dr. Ramanan's paper on IL-6 in uveitic macular edema, it is there. Although the other agents, they have used adalimumab, but only for macular edema they have used IL-6. But guiding this therapy, even when patients come from, I see a lot of patients from institutes, taking a decision on the therapy is a big thing. What agent
You
to
know,
use?
tocilizumab works very well for macular edema, but it's never the drug which you will give right in the beginning.
Yeah,
You
absolutely.
know, our pediatric rheumatologists do not straight away
Yeah.
do. And many times the macular edema will respond on your standard of care, which is methotrexate, steroids, and if you want to add even anti-TNF. It's only very few patients where it will persist, and what she's showing is one of those rare patients. That does not automatically mean that next child with macular edema you go on tocilizumab.
So, yeah, that was the main. So, what made me think of that topic was because I've seen cases where people are giving, repeated Ozurdex, repeated posterior subtenon, it's not working and doing more harm than good. So, I would like to summarize the session. Thanks to Dr. Vishali ma'am for showing such wonderful cases of pigmentary fundus. And, I got to think of this topic when I realized that a lot of patients with dystrophies and, all these diseases are referred to our clinic with labeled as uveitis, even things like PPCRA. So it's important to note that these, eyes, whether they have uveitis or not, so by relevant imaging as ma'am showed, a lot of cases where we don't have any clue of what's going on as shown by Dr. Biswas. So you know what modality to choose upon, you know what to think of. And of course, the use of fluorescein angiography, Dr. Soumya beautifully showed where it is required and where it is not. And just to add to that list, I think toxoplasmic retinochoroiditis, you straight away make a diagnosis and you really don't have to wait for your fluorescein angiography. Patients' complaints, Mudit has highlighted. And anywhere you have a patient, who's bothered by floaters or scotomas for that matter, if you're not able to find anything in the eye, in the anterior segment or in the posterior segment, at least you can do a visual field, specifically when the patient has scotoma, or do an OCT or non-invasive imaging, or at the most you can do a fluorescein angiography. So with this, we come to the end of this instruction course. I thank all my speakers, my co-instructors for the beautiful presentations they've made. I understand the topics were not very easy, but thank you for doing an amazing job. Thank you for the audience for making the hall full and listening to us and making our course worthwhile. Thank you very much.